Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose only. This lecture will be also very useful to you in your theory exam as well as in your oral exams. And once in a while you will see this group of people in your everyday practice. So in continuity the previous series on neurology, today we'll be discussing on what we call a cerebral palsy. So it is one of the disorder which involves the developmental part of the brain and leads to a disorder we call as a cerebral palsy, or also called as a Little's disease, or previously it was also labeled as a brain paralysis. But now a word which is only being utilized is cerebral palsy, and it is an irreversible damage. Hence, usually there is no recovery. You can have a symptomatic treatment in case of cerebral palsy. So we'll be discussing under these common headings. Definition. It is a Latin word. Cerebrum means cerebral hemisphere. That is the affected part of the brain. And palsy means paralysis. So lack of muscle control due to developmental defect in cerebral hemisphere, that is labeled as cerebral palsy. And there are classification wise etiological classification, topographical, physiological and functional. These are the four groups under which cerebral palsy is being classified. So it is a static encephalopathy. Encephalo means brain, pathy means involvement. It is the involvement of the brain which is static. It is non-progressive. So whatever damage has taken place, now there is no further progress. So encephalopathy is a brain injury that is non-progressive disorder which involves two groups of neurons, that is pyramidal tract, we call upper motor neuron, and we get involvement of extrapyramidal system which will have a disorders of posture and movements, and this will be very frequently associated with seizures, speech disturbances, visual disturbances, cognitive dysfunction, as well as spastic paralysis. And if there is an involvement of the basal ganglia, it will be associated with involuntary movements. This will be the group of symptoms and signs which will be there in a person who gets cerebral palsy. So main, it is a motor functional disorders which is permanent, non-progressive, and it is present at birth or shortly after the birth. As it is non-progressive and permanent, it is non-curable because it is permanent damage, and as it is a permanent, it is a lifelong. It is non-progressive, so damage cannot worsen, but maybe right from birth or little after birth. So that will be acquired group. So we'll be further going into etiology, that time will be mentioning. So it can be developmental malformation where brain fails to develop correctly. Neurological damage can occur before or during or after delivery. So if it is after delivery, it is usually we put them into a group called acquired group. But before labor, it will be congenital. During and after will be more of acquired group. There can be some person with RH incompatibility or illnesses or severe hypoxia. We'll be going through in detail regarding etiology. But major group is unknown etiology. The brain damage can be because of bleeding or because of brain malformation or traumatic damage to the brain during delivery or after delivery, or severe hypoxia or infections, or because of toxins, and a big group we call as unknown etiology. So insult to the brain or injury to the brain is very frequently during developmental period, where you get involvement of the motor neurons, that is pyramidal tract, and as it is a permanent damage, it is not curable and it does not progress. So it is non-progressive, or we call static. Any regression or deterioration of motor or intellectual skill should be a prompt research for a degenerative disorders, but not because of cerebral palsy. The treatment will help to improve the function, but it is non-curable. So etiology is divided into three groups. Antenatal factors, which is accounting for almost 80% of the group. During intrapartum period, 10%, and postpartum, 10%. So etiology is divided into developmental defect, which will be more in antenatal factors or genetic factors. But intrapartum period and postpartum period, metabolic, ischemic, infections, etc. will be more during intrapartum and postpartum period. Now, during an antenatal factor, infections in mother, particularly German measles, shingles, a person may have GDM, female patient may have GDM, or toxemia of pregnancy or RH incompatibility. All these factors can result into developmental defect, or there may be a genetic factor. But during intrapartum period, metabolic cause can predispose like asphyxia, or during delivery, birth injury, or premature delivery, etc. can predispose to cerebral palsy. During postpartum period, immediately after birth, hyperpyrexia, encephalitis, any head injury, severe hypoxia, or any toxic drugs or chemicals, or intracranial hemorrhage, or because of blood clot. All these factors can end up with cerebral palsy. If you look in this particular, you can see before birth, almost 75% of the group. During birth, 5 to 15%, and after birth, 10 to 20%. So almost, we can say, almost 75%, that is 3/4 of the group, is antenatal. And during birth, that is during delivery and after birth, will be accounting for another 25% groups. So major group is antenatal, this group, antenatal factors, and 20 to 25% will be intrapartum or postpartum period. Certain causes are preventable and treatable, they should be taken care. As far as the pathophysiology is concerned, during antepartum period, the factors in the mother can predispose to maldevelopment. And another factor which may be responsible is genetic factor. While during postpartum period, there can be damage because of severe hypoxia, or because of traumatic injury, or because of infections, or RH incompatibility, etc. And after delivery, damage to the newborn, either premature or because of hypoxia, infection, chemicals, drugs, etc. can predispose to damage to the brain. And depending upon the damage to the brain, if it is a pyramidal tract damage, person will develop spastic motor paralysis, mainly because of the damage to the cerebral cortex, that is motor cortex or internal capsule or corticospinal tracts. While if there is a damage to basal ganglia or thalamus or subthalamic nucleus, they will develop involuntary movement disorders, or we call extrapyramidal symptoms. And if there is a damage to cerebellum, it will produce ataxic variety. There may be combination of 2 or 3 things together. You can have pyramidal damage, extrapyramidal damage, you can have a cerebellar damage. Then it is a mixed group. So you can have any one of those. So whenever the pyramidal tract is damaged or corticospinal tract or we call as an internal capsule, etc., you can have spastic variety of paraplegia or hemiplegia or monoplegia, etc. Because brain will not be able to send the appropriate signals to muscles when to contract and when to relax, and that will result into spastic type of a muscle paralysis. Certain words which are being very commonly utilized depending upon the etiology, topographical features, physiological and functional. So depending upon that, we divide into certain groups. So according to the neurological deficit, type of the movement involved, affected limb and severity. So we'll be using all those terms. So etiological wise, prenatal, natal and postnatal. Topographical wise, which part of the body is being involved? If one limb is involved, monoplegic, both lower limb involved, paraplegic, three limbs involved, triplegic, all the four limb involved, quadriplegic. Diplegic means usually where the lower limbs are more involved and upper limb are less involved. Then it is labeled as diplegic. If on one side you get upper limb and lower limb involved, it is hemiplegic. And double hemiplegic is means of both side hemiplegia with one part more involved as compared to other part, then it is called double hemiplegic. So there are few terms like hemiplegic, monoplegic, paraplegic, diplegic, quadriplegic, double hemiplegic, and one more word is total body involvement. The most common variety which we come across is spastic variety, which is accounting for 70 to 80%, which can be further divided upon the depending upon the number of limbs involved. Quadriplegic is all the four extremity involves along with trunk involvement, and it is accounting for 10 to 15%. Diplegic means lower extremities are more affected as compared to upper extremities. In quadriplegia, it is called 30 to 40% of those groups. In hemiplegia, one side of the body is involved, that is arm and leg involved, which is accounting for 20 to 30% indirectly. Diplegia and hemiplegia is a major group, and then comes quadriplegia. Monoplegia is usually rare, which may be either upper limb or lower limb involved. If there is an involvement of basal ganglia, it will produce involuntary movement. It is called dyskinetic variety of cerebral palsy, which is accounting for 10 to 15%. And if there is an involvement of the cerebellum, which is less than 5% of the group, person will have ataxic type of a palsy. It is characterized by unsteadiness, ataxic gait, and cerebellar signs. That will be ataxic cerebral palsy, which is because of involvement of cerebellum. These are the three main common groups which you can come across. And you can have a mixture of the two, like spastic with dyskinetic with ataxic, etc. can be present. That is we call as a mixed group. Physiological wise, we divide into spastic, dyskinetic, ataxic. Very rarely we come across atonic, and there is one separate word which is being utilized, rigid, same as spastic only. Depending upon the severity wise, class 1, class 2, class 3 and class 4. Class 1, no limitation of physical activity. Class 2, mild limitation of physical activity. Class 3 is moderate limitation of activity. And class 4 is called severe, where person is almost bedridden. That is that particular group. So normally we use spastic, we call dyskinetic and ataxic. These are the three common groups which are being described, and plus you can have a mixture of the two. So in that dyskinetic groups, it can be athetoid variety. You can have a tremors which can be there, and very rarely we have got atonic variety. So spastic, in extrapyramidal we can have athetoid, and we can have ataxic in the case of a damage to cerebellum, and mixed variety will be a mixture of the two, that is spastic plus what we call as dyskinetic. Spastic plus dyskinetic. Sorry, here I've forgotten to mention that. In a mixed variety, it will be spastic plus dyskinetic group, or it can be spastic plus ataxic group. So, any one of them. So, severity wise, mild, moderate, and severe. 20% of the case are mild, 50% are moderate, and 30% of the people will be totally incapacitated or bedridden. If we go through the percentage of cerebral palsy, non-spastic variety will be 23%, where it can be dyskinetic plus mixed variety, where spasticity is not there. It is almost 23%, and you can see total spastic variety is 77%. And of that, diplegia is 21, hemiplegia is 21, and quadriplegia is also 23. This is in this series. But we have seen that quadriplegia, diplegia is more common as compared to monoplegia. So this is classification we already mentioned. Class 1 almost nearly normal, class 2 mild, class 3 moderate, class 4 severe. Clinical features we can divide upon the clinical findings. Like spastic variety is almost 65 to we can call up to almost 80% of the time it is spastic variety, where there is a damage to pyramidal tract. We'll be mentioning some of the things. While in a extrapyramidal damage, the most common variety which they present is athetosis, which is a classical variety of a dyskinesia. So you can have a dystonic athetosis. Occasionally you can have a chorea form, and along with rigidity, it can be rigid athetosis. When there is a damage to cerebellum, it will be ataxic variety. And in a mixed variety, most commonly, extrapyramidal with spastic is most common. So both pyramidal and extrapyramidal symptom signs may be together. So commonest variety is a spastic variety. Second common variety is athetosis. And third variety which is common is a mixed group. While ataxic group is less common and atonic group is also less common. You can have involvement right from head till toe, but it is static, means non-progressive, and it is irreversible damage. So it is not curable. If we get the damage to pyramidal tract, tone is increased. Because tone is increased, the muscles are spastic. Because there is an increased tone, dip tendon reflexes are brisk. Clonus may be elicitable, particularly ankle clonus and patellar clonus. Very early, there will be contracture because of disuse atrophy, and person will have a severe spasm. Primitive reflex like abdominal reflex etc. may be delayed or absent, and plantar reflex will be extensive. Involuntary movement are usually not seen unless it is associated with extrapyramidal. In case of an extrapyramidal damage, tone is usually increased. There is a rigidity. Dip tendon reflex are normal. Sometimes you can have a brisk reflexes. Clonus may be occasionally demonstrable. Contractures are not common. They are usually in a late stage. Primitive reflex may be preserved. So plantar reflex will be flexor. And involuntary movements are invariably always present. And particularly it is a athetosis variety. Occasionally chorea form movement are present. And you can have a rigidity along with that. But when both are together, you will have a combination of both these findings together. So classical upper motor neuron with pyramidal damage, and this is basal ganglia damage. So symptoms can be abnormal strength, particularly the strength is reduced. Abnormal reflex means dip tendon reflex is brisk, clonus may be demonstrable, and plantar reflex in case of pyramidal tract damage, it will be extensor. There will be delayed motor contraction. Cognitive function may be affected. Person is invariably handicapped. If there is a cerebellar involvement, person will have ataxia and imbalance. There will be loss of control and coordination will be affected if cerebellum is affected, and tone will be abnormal in case of extrapyramidal system as well as in case of cerebellar damage. So this will be all different symptoms and signs which can be present. So some person puts a word to remember posture. P for posturing and poor muscle control and strength. O for oropharyngeal problem, because of a increased tone in those muscle, person finds difficulty in swallowing. Even gag reflex is exaggerated. Person can have strabismus, squint. Person will invariably have hypertonia and increased tone, that is we call spasticity. And in case of extrapyramidal, there will be rigidity. Only in case of a pure cerebellar damage, you can have little amount of hypotonia. Usually there will be maldevelopment of the brain and person will develop later on because of disuse atrophy and contractures. Reflexes, dip tendon reflex will be exaggerated or brisk and clonus may be elicitable. So, movement disorders in pyramidal tract, spasticity, basal ganglia, Parkinson syndrome or dyskinesia or stereoform movement. In case of Parkinsonism, akinesia with rigidity. In case of a dyskinetic movement, choreiform movement, dystonia, myoclonus, tremors or tics may be present. And in case of a stereotype movement, gesticulation, akathisia, compulsion, mannerism may be seen. If person has got a pure motor signs, it will be more in favor of pyramidal tract damage, pure pyramidal tract damage. And if there is a cerebellar damage, person will have ataxic gaits, ataxia and imbalance. So physiologically you can classify into spastic, dyskinetic and ataxic, and mixture you will call as a mixed variety. Distribution wise, diplegia, quadriplegia and hemiplegia are more common. Monoplegia is rather rare. So typical upper limb, lower limb involved, hemiplegia. Lower limb more involved as compared to upper limb, but all the four limb are involved, lower limb more involved. The word utilized is diplegia. When all the four limbs are involved, you call as a quadriplegia. If there is a dyskinetic movement, particularly athetoid movement, it is called athetoid cerebral palsy. And if there is a dystonic movement, it is called as a dystonic cerebral palsy, where there will be a global involvement and particularly you will have a basal ganglia involvement. And if there is an involvement of the cerebellum, person will have a ataxia with involvement of the maybe whole body. So this will be all the different types of presentation with which the person can come to you. Say one limb involved, monoplegia. If upper limb and lower limb involved, where upper limb is more involved, you use the word hemiplegia. Both lower limb involved, paraplegia. When all the four limb involved but two lower limb more involved as compared to upper limb, diplegia. All four limb involved, quadriplegia. When upper limb are more involved as compared to lower limb and all four are involved, the word utilized is double hemiplegia. And when face, neck and upper limb, lower limb completely involved, it is called total body involvement. These are all the different types of presentation which you can come across. This is monoplegia, this is hemiplegia, this is bilateral hemiplegia, paraplegia, diplegia and total body. So arms and leg involved, hemiplegia. Two lower limb more involved as compared to upper limb, diplegia or paraplegia was the common word which was being utilized. But if both upper limb are involved and lower limb are also involved and equally involved, quadriplegia. Lower limb more involved as compared to upper limb, diplegia. And if upper limb are more involved as compared to lower limb and all the four limb involved, then it is called bilateral hemiplegia. These are all the different terms which are being utilized. So according to the presentation, monoplegia, diplegia, hemiplegia, triplegia, quadriplegia, and double hemiplegia, where upper limb are more involved as compared to lower limb, and person has got bilateral involvement. So spastic quadriplegia, diplegia, spastic double hemiplegia, and spastic hemiplegia. We have all utilized all these terms. As far as investigation is concerned, the most common investigation is a clinical examination, which is most helpful to put them into different groups, topographical and with involvement of which part of the brain. MRI and CT scan will help you to identify the area of involvement. EEG will tell you regarding involvement of the cerebral cortical region. Laboratory and radiological workup is usually not very beneficial, but to find out the metabolic groups, it may be helpful. And assessment tools, there are a lot of different tools which are being available for finding out the developmental of motor skills. So one of that is Denver test, which can be utilized. Mainly clinical history, physical examination, and then you go for MRI or CT, and you can go for quantitative gait analysis, etc. So main common investigation is clinical, followed by CT or MRI of brain, and you can go for torch test during pregnancy, urine examination for metabolic disorders, and you can go for chromosomal analysis to find out the genetic defects. So history is first. So good history examination is absolutely necessary. And then you can go for MRI and CT scan. If it is normal, then you can go for genetic study, consider metabolic or genetic factor, and go for metabolic disorders or go for genetic disorders. And if there is an abnormality, you can pick up which part of the brain is being damaged, etc., and you can go further. As far as differential diagnosis is concerned, you should always keep it in mind. Another group of disorder which can present in seminar, neurodegenerative disorders. Occasionally you can come across with spinal cord disorders, muscle we call myopathy, and absolutely uncommon primary mental retardation, which can be because of say even cretinism, hypothyroidism, congenital hypothyroidism. You can have that in a differential diagnosis. As far as management is concerned, we know that it is not curable, so no treatment to cure the cerebral palsy. But brain damage cannot be corrected, but you can reduce the morbidity by early identification and multidisciplinary care, which will include multiple. We'll be mentioning those, like improvement in preserved function. You can increase the development of compensatory functions, encourage the independence, maintain normal growth, facilitate the communication, and ensure good dental hygiene, etc., and rehabilitation. These are the main goal. And for that, usually physiotherapy, orthotics, control of spasticity by medicines or by surgical intervention. You might require some time orthopedic surgery to reduce the amount of deformities. So management will require a good family support. You will have to educate the parents, and you will have to give good physiotherapy, occupational therapy, adjuvant therapy, speech therapy, and occasionally you might require surgical intervention for correcting the deformities. You might require even a psychotherapy, psychiatrist, etc. Indirectly, occupational therapy, physiotherapy plays a major role. Another is speech therapy, and then later on person may require surgical intervention. Occasionally the drugs like baclofen or Botox can be of help to reduce the amount of spastic muscle deformities. Complications all are because of the permanent brain damage like spasticity, weakness, clonus, seizures, visual compromise, deformities, dislocation, deformities like kyphoscoliosis, urinary tract infection, constipation, etc. are quite common. And you can have irreversible neurological damage like hemiplegia, monoplegia, paraplegia, diplegia, double hemiplegia, total body involvement, quadriplegia, etc. can be there. So cognitive function defects, seizures, motor dysfunctions, and behavior dysfunctions will be a major problem because these are irreversible damage, non-curable, may not be progressive, non-progressive, but non-curable. So I end my lecture here. If you like this particular lecture, don't forget to press button like, subscribe. You can give your comment so I can improve. If you feel that it is beneficial to your friends, you can share with your friends. I feel this will be benefited to you in your oral exam as well as your theory exams. And once in a while you will see a newborn with this particular disorder we call cerebral palsy. So thank you very much for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. See you in next lecture.